You have lipedema? Isn't that thing Mama June has that she says is life-threatening? Actually, that's lipedema. Lipedema is that thing where after cancer treatment, one of your limbs gets disproportionately large. Nope, that's lymphedema. Lipedema is a large semi-aquatic mammal from Africa. That's a hippopotamus. Hi, I'm T-Flex, and today I'm gonna tell you what lipedema is. Maybe you've got a loved one who has it, maybe your doctor has told you that you have it. Maybe you've seen some photos of fat ladies on the internet who have it and are like, oh, that's what my legs look like. Maybe you're curious because you know an Instagram person who has it. Maybe you're one of my friends and relatives watching all my YouTube videos out of a sense of politeness. It's probably the last one. Thanks, Mom. Whatever one of those it is, you're in the right place. I mean, if you think you have it, this isn't the right place for you. Ideally, your doctor would know what lipedema is and you'd be having this conversation with them. So I'm what you got. I'm so sorry. I don't have a medical degree. Do not take this as medical advice. I don't know any of this stuff. This is just me compiling a bunch of things I read on the internet and presenting it to you with more fart jokes. I'm just a software engineer, so I'm very, very good at Googling. You wouldn't think that that's necessary, but you'd be wrong. Sorry, because lipedema is a condition that primarily affects fat women, you're generally going to find out about it on Facebook, YouTube, or the Instagram page of a nutritionist who's trying to sell you homeopathy drops. Sorry, let's try this again. Lipedema is a chronic condition that results in fat legs. It was first identified in the United States at the Mayo Clinic in 1940 and described in a paper called Lipedema of the Legs, a syndrome characterized by fat legs and edema. That's basically it. Fat legs. The number one identifying factor of lipedema. Big ol' subcutaneous fat deposits that aren't like proportional, that tend to affect the lower body more than the upper body. It's usually the thighs, but it can be anywhere that you might describe as gynoid fat. Fat deposits associated with estrogen. Butt, hips, calves, arms, and at later stages, it can basically affect anywhere that you can have subcutaneous fat. But generally, the typical presentation is someone with a slim torso and fat legs. And then the feet, hands, and face are generally like completely spared. And it's lumpy. Instead of your fat being very like smoothed and soft, it tends to grow into these pearl-sized nodules that get larger and larger as your lipedema progresses. It's also associated with pain, tenderness, and easy bruising of affected areas. Different people have different amounts of pain, and it doesn't necessarily correlate to how advanced your lipedema is. For me, I mostly feel fine, but I get like enormous bruises from minor injuries and minor bruises from mystery injuries I have no memory of. I mostly just hurt if my cat jumps on my lap or if I get my blood pressure taken at the doctor's office. But other people, they have like extremely painful, like burning sensations if anyone touches their fat. And it comes in stages. At stage 1, you're mostly gonna look like a normal person with slightly disproportionate legs. At stage 2, you start looking more like a nylon stocking full of grapes. And then at stage 3, you can start developing very large fat masses that can impair your gait and your ability to move. Sometimes lymphedema is also present, and that's called lipolymphedema. It used to be called stage 4, but now a lot of doctors are making that its own thing because they've discovered that you can have lipolymphedema even at earlier stages. So it's a mystery. Which brings us to the hardest part about talking about lipedema. That's all that anyone agrees on. The rest is completely controversial, and like the 6 doctors studying it all have widely varying opinions about things like what causes it, how do you treat it, like if you don't have some of those symptoms but others, do you still have lipedema? I mean, they all agree that it's a thing. Like, of all the doctors studying lipedema, there's not a single one who's like, maybe they're lying and they're just fat. But for all the other stuff, there's, you know, you kind of just have to like read everybody's papers and then make up your own mind because there isn't a solid scientific consensus or treatment plan for any of it. Basically, the only thing all the doctors agree on is that lipedema is a terrible name, and if they picked something better, they could spend more time doing research and less time going, no, it's not lymphedema. It's similar, but it's different. And so I'm going to try really hard to break down the various opinions of different doctors and then link you to their YouTube lectures that you can go off and watch them. In the future, I'd really like to make more videos going in depth on each and every one of those issues and what are the prevailing scientific theories on any of them, but there really isn't a solid consensus on a lot of this, so you've really just gotta like look at it and figure it out. So let's hit it. Controversy 1, what causes it? It's genetic. Most doctors agree that there's some kind of a genetic component to it. No one has identified a gene, but there is a study that indicates that about 60% of women with lipedema have a close relative who either has it or has the symptoms. But beyond that, it's all way up in the air. Like, even about simple questions like, is it edema? You think it would be. It's in the name, but remember, they all hate the name. Dr. Burst and Dr. Erbacher wrote this 5-part paper called Lipedema Myths and Facts, in which they break down a lot of these controversies about lipedema, and one of them is like, there's no real scientific evidence that there actually is any edema involved. They all hate the name. Okay, so basically, you take a woman with lipedema, a woman with lymphedema, and just a regular metabolically healthy fat lady, and you put them all under an ultrasound. And what you can see is that the woman with lymphedema has clear fluid in her fat tissue, but the women with lipedema and the woman with regular metabolic fat don't. In Germany, the UK, and the Netherlands, the prevailing thought is that there's no edema in lipedema, and when they're treating lipedema, they're not focusing on edema as a realm of treatment. The prevailing theory there is that lipedema is a condition of the fat tissue. Fat is gained in a metabolically normal or hormonally driven way, but it forms these nodules that are painful and don't respond to diet and exercise. The pain of the condition is caused by low-grade inflammation and hypoxia. But then you compare that to America, where we've got Dr. David Amron and Our Lady of Perpetual Lumps, Dr. Karen Herbst. Okay, hang on, can I just talk about how everybody loves Dr. Karen? She's very actively studying lipedema, and she's very nice, and like, she's very online. Like, half of all of the lectures you can find on YouTube are all Dr. Karen Herbst. I mean, her colleagues all talk about her like this.
And then finally, Karen Herbst for just being Karen Herbst.
And every Facebook group is like, oh my God, you guys, Dr. Herbst is taking telehealth appointments. Oh my God, you guys. Anyway, Dr. Karen and the other Americans, they're forwarding this theory that it's not just a condition of the fat, it's of all the loose connective tissue. So that can mean like tendons and ligaments and lymph and all your connective stuff. Something is causing inflammation and edema, but you can't see it on an ultrasound because it's not in the free tissue fluid like you'd see in lymphedema. It's bound to the glucosaminoglycans in the extracellular matrix. See? Easy. This is the stuff I have to read. And this is the other reason that I like Dr. Herbst, is she's somehow able to use the phrase glucosaminoglycans in the extracellular matrix like 14 times a lecture. And then that inflammation becomes fibrosis, and it's the fibrosis that makes the fat into nodules that are inaccessible to diet and exercise. She says something like 50% of women with lipedema have hypermobile joints, or could be described as having Ehlers-Danlos or Ehlers-Danlos hypermobility spectrum disorder. I don't know what that is, and if anyone ever tried to describe me as hypermobile, they'd have to fight my powerlifting coach. But 50%. So I definitely recommend that if you're not sure what you think, you dig up both of those schools of thought and like see what they all have to say, because all of it is very well researched and extremely interesting reading. Controversy 2. If you don't have pain, do you have lipedema? Maybe. That's a controversial topic, but it's the kind of controversial topic where everyone's like, golly gee, what do you think about that, Steve? Oh, maybe. Like, it's not like an angry controversy. Dr. Herbst said that, yeah, even in that 1951 Wald, Allen, and Hines paper, only something like 40 to 50% of women with lipedema had pain or tenderness. There are non-typical presentations of lipedema, but others like Dr. Stephen Dean see a significant number of women who report the disproportionate legs but not the pain, and say maybe that should be a separate categorization. Call that something like lipohypertrophy. Does it matter? For you, probably not. Whether the doctor you're seeing wants to call it lipedema or lipohypertrophy, the only difference is going to be that if you don't have pain, you might not be doing conservative treatments that are meant to target pain. None of them are saying lipedema is real, but lipohypertrophy isn't. So just go with it. Controversy 3, is it progressive? So I don't know about you, but when I first Googled lipedema, I had 2 very strong reactions. Oh my God, those are my legs. Oh my God, is that gonna happen to my legs? There is disagreement in the medical establishment about the degree to which lipedema is progressive. And I think those opinions really fall into 3 general categories. Group 1 is those European folks that we mentioned earlier. They're saying there's nothing about lipedema that causes fat growth. Periods of hormonal change, like puberty, pregnancy, and menopause, those cause fat growth, as does lifestyle factors. But lipedema makes some of that normal fat growth painful and inaccessible to diet and exercise. The majority of your fat is non-painful and responsive to diet and exercise. So if you're not going through those periods of hormonal change regularly, you're probably not going to have progressive lipedema. And doctors in this camp report treating lipedema patients for periods of like 10 years, and they're not seeing them grow significantly larger. That is great news. Group 2 is kind of in the middle, like where they're saying there's nothing about lipedema that necessarily causes fat growth, but the fact that it causes some percentage of your fat to be unresponsive to diet and exercise means by definition, it is kind of progressive. If you can put fuel into your fat cells but not take it back out again, then by definition, eventually that's going to cause some amount of fat gain. People like to talk about fat cells as if they're just like this garbage can, and then so you eat a bunch of food, it goes into your bloodstream, and if you don't use it all up by the end of the day, your body's just gonna shove it all into your fat cells. But that's not really how it works. You're not eating like 1.4 calories a minute every minute of every day. It's a normal process to every time you're eating food, some's going in the fat cells, taking it out again, in and out all day long. If part of that isn't working so well, over time, you could gain fat. So for doctors who believe this, they think it's really extremely important that women who have lipedema focus on weight maintenance. Don't go all nutso-butso on the fat loss so that you end up yo-yoing, because you're going to not be able to lose the lipedema fat and you're going to gain more lipedema fat when you put the weight back on. But by using lifestyle intervention to maintain weight, people can prevent the disease from progressing. And then some other doctors think that lipedema in and of itself is progressive. Something causes inflammation and fluid retention. Inflammation becomes fibrosis, and that fibrosis is what creates the metabolically inactive fat. For people who believe this hypothesis, it's extremely important not just to maintain weight, but to reduce inflammation. They recommend diet, exercise, a whole bunch of different things aimed at reducing that inflammation so that it prevents the fibrosis and prevents the growth of additional lipedema tissue. And who's right? I don't know. That could be a whole entire different video to really dive into like what they think about that. There are some women with lipedema who stay the same size for decades, or there are women who have bariatric surgery and then lose most of their fat, leaving only some lipedema tissue behind. And in doing that, they reduce their pain and they feel fine. Other women, they have bariatric surgery and they lose weight on their torso and their face and their arms and their face, but not on their legs. And they still have just as much pain as before. There might even be different presentations of lipedema where some people have a stable condition and others have a progressive one. I don't know. Women are having enough trouble getting like diagnosis and treatment, never mind state-of-the-art research. For me, like I know I have something progressive going on. I'm a 200-pound woman on a 1,200 calorie diet, and every time I eat a carb, I gain 4 pounds. Like, that's not normal. But any of that information doesn't preclude the people in the first two categories from being right about what causes lipedema weight growth. My estrogen is twice as high as it's supposed to be. It's totally possible that I'm just experiencing hormonal weight gain because of my messed up hormones, and other women with lipedema don't have that problem. Other women could just be gaining weight during puberty and menopause and then mostly staying stable. Who knows? Mysteries! Controversy 4. How do you treat it? Well, you got two options: broccoli and self-massage, or surgery. That's kind of what happens when you have like a poorly studied and underdiagnosed condition that primarily affects fat women. There's no big consensus on what the biological mechanism by which this comes to pass is. So it's not like they can have one traditional method of treatment and if it doesn't work, try the next one. Everybody's just coming at it from different angles. There's the doctors coming at this from the vascular side or from the endocrinology side who have these patients coming to them with pain and lack of mobility, and they're trying to find the right conservative treatments to give them the best quality of life. And those doctors are tending towards conservative treatments. But then there's the doctors coming at it from the plastic surgery side, where they mostly were just doing like regular liposuction on women who had predominantly aesthetic concerns. And then they found that, oh, lipedema is a thing. There's a bunch of women who want fat loss who have a very different presentation. How can we make plastic surgery work better for women with lipedema? So that might mean like taking a larger volume of fat rather than sculpting in a more aesthetically pleasing way, removing more of the nodules, breaking down the fibrosis, sparing the lymph nodes. They do plastic surgery. So they're all focused on doing better plastic surgery for lipedema. And that's not to say that either one of those groups are wrong, or like, it's just they're coming at it from different angles. It's hard enough to try to find one of the 6 people in the United States treating this crap. Like, it means that there's already like a teeny tiny number of doctors who even know what this is. But what that means is that what you get told is the best way to treat your lipedema is going to be very biased by who's the first guy you talk to. What kind of doctor you see is going to determine if they're going to say put on special pants or $20,000 of surgery. It could be either. And I don't know what to tell you because that's all controversial. Like, watch any of the videos that I linked you to in the beginning part of this video, and you will see that all of them have very differing opinions on what's the most effective thing to do to treat lipedema. Most of them are basically saying, throw all these conservative options out first, try all of the things you can possibly do, and if they don't work, do the surgery. But then people have different opinions there anyway. But from what I've been able to see, it seems like the least controversial thing you can say is to maintain weight on a healthy diet is step one, and it won't hurt to have an anti-inflammatory diet. And that's not a specific plan. Keto is anti-inflammatory, vegan is anti-inflammatory, intermittent fasting is anti-inflammatory, the RAD diet is anti-inflammatory. If you want to know more about that, I did a video where I tried it and I was bad at it, but you might not be. Elimination diets are anti-inflammatory. Like even just like eliminating like sugar and processed carbohydrates is anti-inflammatory. There's a million different things you can do to make your existing diet less inflammatory, and that's a great thing to do. Beyond that, daily compression garments are recommended by almost everybody, and that can be like regular stretchy gym pants up to like prescription customized compression. Some people say wear them all day, but most people say at least wear them when you're exercising. And then there's things like vibration plates, manual lymphatic drainage, fascia blasting, all sorts of different things that are targeted on breaking up fibrotic tissue and moving lymph. And those may or may not help you depending on if you're mostly having pain, mostly having weight gain. I don't know. You gotta look up all the stupid videos. There's so many videos and you gotta look at them all. And when do you need surgery? The big debate on surgery is mainly around two separate questions. Is surgery a permanent fix? Like if you get the surgery, is your lipedema fat gone forever? Is it going to come back there in the future, or is it just gonna pop up somewhere else? Some people say that that happens. Like they're supposed to do surgery on 5 different places in their body. They remove it from their thighs and all of a sudden it's growing on their stomach. But for other people, they're saying, yeah, I had the surgery once and not only was it gone forever, but it made it a lot easier for me to lose regular fat. People respond very differently to surgery. So you might have to search these people out and see if their case is like yours or not. And another big question is, do women who have both lipedema fat and a significant amount of regular metabolic fat benefit from surgery? It's more of an open question. For some doctors, they think that women who have a significant amount of regular metabolic fat can really improve their symptoms and have a much better quality of life if they just lose that regular metabolic fat. It puts less pressure on the lipedema tissue and they do a lot better without ever having to do any of those more serious interventions. And especially if you're dealing with continued weight gain, it's more likely that nodules will come back after a surgery. For these doctors, they're often saying, if you're gonna do a surgery, do a bariatric surgery, because it has a pretty good chance of helping you to reduce both your metabolic fat and your lipedema fat. But for other doctors, they're saying that even women who are larger can get a great benefit from removing lipedema nodules, especially if they cause pain. By removing those nodules, they're going to have much better quality of life and better mobility that'll make them better able to be physically active and lose obesity fat. Both of those are valid perspectives, and it's up to you to determine what side of that fence you want to lie on. It's still a big question that's up in the air, and the moral of the story is keep yourself out of other people's medical decisions because the doctors don't even know the right answer, so don't be a judgy McJudgerson. Whew, that's what I got. That is my top level broad brush understanding of lipedema. I probably messed up on a bunch of stuff there. If there's anything I'm wrong about, please correct me in the comments. If there's anything I've left out, please tell me about it because I want to make sure I'm not leaving anything out here. Also, I want to get us out of here at a reasonable hour. So there's definitely things that I didn't cover. What should I cover in the future? I want to hear about it. Anyway, I hope you come out of this with a couple different places where you can start your own Google adventure. And I hope you've learned a little bit more about what hippopotamus is. I mean, lipedema is. This name is the worst. See ya.